Well, it's my pleasure to introduce Dr. Weiwen Chen. She's an accomplished endocrinologist. She has made significant contributions to the field of bone health and fracture care. She completed her medical degree at the University of Western Australia and is a fellow of Royal Australasian College of Physicians. That's a little mouthful for me.
It's all good.
Australasian. So she received her PhD from University of New South Wales in Sydney under the supervision of Professor Jacqueline Center, focused on health outcomes following fractures. She has a clinical appointment currently at St. Vincent's Hospital in Sydney, where she co-leads endocrine oncology and fracture prevention. She has been widely recognized and received numerous awards. And beyond her clinical duties, she plays a key role in several national and international committees, and has been key in establishing standards through the Australian. This Australasian is making me.
Oh, it's kind of tricky. No, it's Australian, except for the college.
Yeah. So a New Zealand Hip Fracture Registry. So today, Dr. Chen is going to talk to us about post-fracture outcomes.
Thank you for the kind introduction, and thank you for having me today. These are my disclosures, which should not be, it's not involved in any of this work. So the objectives of my talk are, and I'd like to convince you to consider the long-term outcomes of fractures, understand the interaction between fractures and comorbidities, because everyone blames it on the comorbidities, and possibly identify patients who are likely to have poorer outcomes after fractures. So what do we know about fracture mortality? For a long time, we have accepted that increased mortality following fractures for hip and vertebral are well accepted. So across publications, hip between 2 to 6-fold, vertebral 1.8 to 3-fold. There's less data available for other fracture sites, although this is quickly growing, because I think initially due to all the cohort studies being small cohorts, we have not been able to get enough numbers for the other fracture sites. Which brings me to the 45 and up study. So the longest long-term study of healthy aging in Australia. There was a random sampling of the Department of Health Services, and for all of you out there, it's we have universal medical care, so everyone has a Medicare number. So everyone was people were 45 and up for my state, which is this state, the most popular state in Australia. New South Wales was invited to join the study. And the response rate, oversampling of 80 plus above and rural people 2-to-1 ratio to account for people moving and perhaps dying on study. The response rate was nearly 20%, which just works out to be over 250,000 people recruited between 2006 and 2009. They all answered a very, very extensive baseline questionnaire, and they're being followed up at 5-year intervals. And most importantly, they consented for data linkage to all available data sets. So in the center here, we have the 45 and up study with their questionnaire data, and then we were able to pull out the fracture data from the emergency department data collection and the admitted patient data collection, which collects all admissions from private and public hospitals. The death data was from the death registrations and our Bureau of Statistics for mortality data, and we got the lifestyle factors and the comorbidities from the questionnaire. So what do we know about this cohort? They are a very, very healthy cohort, as you can expect, because you have to be able to answer this questionnaire. They're more educated, they're wealthier, they're less likely to smoke, and more likely to report good health. So when I first started out my work, I was trying to compare them to the general New South Wales population, and I clearly failed because then I went in to look into the mortality rates, and you can see the general population are in the darker red and green, especially in your older age groups, in the 70 and the 80 plus. The lighter colors are the people on study. They're about 1/4 to 1/3 of the general population. They're very, very healthy. But despite that, they actually demonstrate similar things to what we understand about fractures. If we look into all fracture sites, because there were enough fractures on this study, obviously, the fracture incidences for all your other fractures other than hip fractures generally increase about 60, 70, but they don't really have the huge inflection point like you see with hip fractures, which we traditionally see in all epidemiology so far. And men demonstrate similar patterns despite having lower incidence as we expect. Now, after correcting for all the variables you can think about, age, lifestyle, and comorbidities, we can see that more fractures are associated with increased mortality. And you can, and men are in green and women are in red. You can see my color preferences. I feel like people are noticing that. For hip fractures, we know you can see it's about 2.5 to 3. But you know what's interesting is pelvic fractures, vertebral fractures, rib fractures, humeral fractures, elbow fractures, distal femur fractures, proximal tib fib fractures, clavicle, and distal, what we call proximal fractures were all associated with increased mortality. And I think what is interesting most is that you can see the humerus, elbow, and femur, the hazard ratios is about the same. And for distal fractures, distal forearm were associated with increased mortality in both women and men, but in ankle, we only saw it in men. So what can we say now about fractures and mortality? Mortality rates are higher in fractured individuals compared to non-fractured individuals in the study. So women between 1.3 to 2.8 fold, men between 1.5 to 3.4. Like I said, all proximal fractures, and the distal fractures, distal forearm, both women and men, and ankle, men only. But I think this is the question I always get asked, right? How much of the risk is attributable to the fracture event? So for women age 60 who has no fracture with 0 comorbidity and 1 comorbidity, 2 comorbidities, and the survival curve 80 to 100%, how do we compare to someone who's 60 who has a humeral fracture? So someone with a woman who was age 60 on the study who had a humeral fracture with no comorbidities did just as poor as someone who had no fractures but 2 comorbidities. And bringing down to the hip fractures, we saw similarly, a humeral fracture plus 1 comorbidity was just as bad as someone who had a hip fracture with no comorbidities. And obviously, if you were a bit older, you did worse as well. So similarly, we can see, oh, sorry, I sped up a bit too much. So this is for women. We saw similar pictures in age 80. Obviously, survival was a bit poorer as because it was older. Now, for time's sake, I haven't gone through the whole lot for men, but we saw similar patterns in men. But obviously, because in general, men actually do worse following fractures. You can see someone with a humeral fracture of 0 did just as bad as someone who had like between 1 and 2 comorbidities, somewhere around there. But what does this mean at a population level? So this brings me to the population attributable fraction, where we can say the proportions of deaths in the entire study population that can be attributable to fracture. So we're able to isolate the exposure to fracture by the heuristic approach. But we can say, so in this study population, for women who had no fracture, no comorbidity, their mortality rate was 4.4 per 1,000 person years. And for if you had fracture only, you did similar to someone who had cardiovascular disease only. So about 17, 18, you did actually poorer than someone who had diabetes, maybe cancer, stroke did worse, thrombosis. And if you had fracture and 1 comorbidity, 34%, you were double obese. So I like graphs, like pictures. So these are the proportion of people, who had no fracture, no comorbidity, about 70%. So fracture only was only 3% of the study. Cardiovascular disease, 4%, diabetes, 4%, cancer was 8%, stroke was 1%, thrombosis 3%, fracture and comorbidity was 1%, and others was 7%. But when we come to the population attributable fraction of deaths, you can see that if you had 1 fracture, you accounted for 9% of deaths, which was similar, was higher than diabetes, and nearly 10%. If you added fracture and 1 comorbidity, 10% plus 9%, 19, it accounted for the same amount of deaths as like cancer. So I think fracture is definitely to say it's not benign. Now for men, in interest of time, I can tell you that they showed similar things as well. The main difference was that because men had more cardiovascular disease, so for their population, attributable fraction for any fracture was slightly lower compared to the cardiovascular disease. So at this point, I can say fracture is an independent risk factor for mortality, comorbidities at additional risk factor, and a population attributable fraction for any fracture for women is 9%, men's 5%. So fractures are common, they contribute significantly to overall population mortality, and they're equivalent to other major diseases. Now, I'd like to bring you back quickly, then this is just a short digressing before I continue with the story, is that because obviously I get this question about this ankle fractures where, you know, it seems a bit strange. So what we can say about ankle fractures currently is that they're very common. The 6 to 17% of all fractures, my orthopedic colleagues tell me that in our state, it actually is the fourth most common presentation to emergency. Someone or something?
Can you mute yourself?
Sorry.
Whoever is speaking.
Where we've accounted for age, sex, and birth cohort. There was an annual excess subsequent fracture risk following ankle fractures. In both men and women, it starts out actually in the first year and increases and gradually goes back down. Overall, there was a 5% excess subsequent fracture risk compared to initial fracture risk in both sexes. And in mortality risk, even with the increased follow-up time and everything, we saw that the excess mortality risk was only seen in men and not in women. So ankle fractures are not benign. They are not your typical osteoporotic fracture patients. They're common, they're younger, and they're heavier. 5% excess subsequent fracture risk, similar for women and men. 10% excess mortality risk in men. I didn't show you this, but the predictors of poor outcomes were diabetes and if they had a proximal subsequent fracture. So what I meant by proximal fractures were those fractures earlier that I showed you that were associated with increased mortality. So can we identify those who are likely to have worse outcomes? And you are going to ask me, so yes, this population is so healthy. What about the real patients you see in clinic like Mr. H? He's 75, he's diabetic, he had an MI about 5 years ago, and he's got stage 2 heart failure. Which brings me to multimorbidity. So multimorbidity defined as the presence of at least two diseases. The prevalence is increasing with age, and generally, I think for most developed societies, we are an aging population. And most of the current healthcare system and guidelines for care are configured for individual diseases. I think there's a need to identify distinct and reliable clusters of chronic diseases that frequently coexist. So we went out to try to see if we can find this coexisting chronic disease, multimorbidity clusters in fracture patients, and to quantify the interaction between multimorbidity and specific fractures on mortality risk. To answer that, we went to the Danish National Patient Registry, where all individuals in Denmark born between 1951 and sustained a low trauma fracture between 2001 and 2014. Low trauma fracture was identified by ICD-10 codes and excluded patients with fractures at 45 age and above, 1996 to 2001, because we wanted the 50 and above. Skull, face, finger, toes, or traffic accident fractures were excluded. So the morbidity data was obtained from the Danish national data as well. Chronic diseases, ICD-10 codes of predefined 32 unique chronic diseases within 5 years of the index fracture. And the death data was from the Danish registry as well. So this is latent class analysis, where we think that looking at like diseases are interrelated physiologically and clinically. It is a statistical method for identifying clusters of correlated disease. So latent class has been found to be superior to count-based and clustering methods. So if we look into it, so we don't observe this. This is latent class X0, Y0, Z0. We see the coordinates A1, C1, D1, B1, but we do a statistical calculation and thing of looking at things. So someone in class 0, for instance, has very little of A, B, C, D, and E. And whereas class X would have A, C, and D more predominantly than the others. So looking at this, we had the 2 million people and went coming down age 50 plus in 2001 with no prior fracture, low trauma fractures. We finally got down to there was 93,000 men to about 200,000 women, and the deaths were until 32/12/2016, so 41,000 and 81,000 women. So we could identify distinct multi-morbidity clusters with men and women. Our analysis between all the Bayesian methods and ICA showed that the optimal models had 5 clusters in men and 4 clusters in women, which were named accordingly to the most common diseases within the clusters. So if I bring you to the next slide where you can see in more. So in men, the 5 clusters that were common between men and women, my apologies, is low multi-morbidity. There's a cardiovascular cluster, there's a diabetic cluster, a malignant cluster, and in men only, there's a hepatic inflammatory cluster as well. Now, for your low multi-morbidity, there was about 60% in women and 67%, so 60% in men, 67% in women. These people were generally aged between 70 and 75. 50 to 60% of them had no comorbidities. So, and then bring down to the cardiovascular disease, it's about 24% in both sexes, and 75 to 85% of them had 3+ comorbidities. And I think this is I have skipped one. The diabetic, I'm saying because of the thing. The diabetic cluster was about 5 and 5.6%, and 50 to 65% of them had 5+ comorbidities. So for your interest, you can see that diabetes, yes, to belong to the diabetic cluster, you definitely had diabetes. But you also see people in cardiovascular and low multi-morbidity that had diabetes. So they're just different sort of patients. People here would be like your HbA1cs of 6.5%, excellent glycemic control, nothing all. But people here would be your complicated diabetics with like lots and lots of macro and microvascular complications. And in the malignant cluster, you also had about 5% in both, age 73, and 60 to 65% with 3+ comorbidities. And in hepatic in men, it's about 5%, age 70, 75% of them had 3+ comorbidities. So what can we say? The clusters are able to distinguish advanced disease patients from those with mild disease. So compared to fracture patients in low multi-morbidity clusters, diabetic clusters, as I said, were very different. They had more complicated diabetes, they had lots more comorbidities. 75% of these diabetic clusters actually had a cardiovascular disease as well. And a malignant cluster, very different, 60 to 65%, 3+ comorbidities. 35% of them also had a cardiovascular disease. So as a whole, for the fracture patients with serious conditions in the whole country, the diabetic cluster was able to capture 95% of complicated diabetes, 80% of renal diseases, and for the malignant cluster, 90% of the metastatic tumors. Now, this brings me to the next part where I talk about interaction between multi-morbidity and fracture sites on access mortality. So proximal fractures were associated with access mortality, like you can see. But you can see that in the low multi-morbidity group, so they were associated with increased mortality risk. But having one of those clusters, those disease clusters, is significantly compounded the access mortality risk that we saw with proximal fractures. And interestingly, you can see, now this might make the question then, you can see the lower leg fractures. In the low multi-morbidity, distal forearm, there was no access. Hand, no access, lower leg, belly. But you can see this is where I think in these fractures mostly then it's the comorbidities that's compounding that's causing the issue. So multi-morbidity, we can say that it compounded excess mortality post proximal fractures. There are specific classes of diseases: low cardiovascular, diabetic, malignant, men and women, and hepatic inflammatory in men. Multi-morbidity classes and proximal fractures compounded excess mortality far greater than by itself. And so what does it mean for us? Potential implications. So we shift from a single disease, to a patient-centered approach. We've actually gone on to use these multi-morbidity classes, and it's been published earlier this year, about it's being at least equal, if not superior, to predicting fracture risk as well, when you're counting single diseases by itself or simple count. So what we say is that, look, can we develop an app from the analysis algorithm to identify multi-morbidity cluster memberships, to triage patients with advanced diseases, provide additional information about other coexisting diseases, and perhaps even convince our patients more to have intervention. The same statistical approach can examine the impact of multi-morbidity clusters on other sentinel health events. And this final bit, we've actually gone on to do the work, and we're just trying to, its preliminary data is out already, where we can see the same clusters, the main 4 clusters, low-morbid, diabetic, cardiovascular, and malignant. The same clusters are seen in cardiac events, pneumonia, UTI. So in the works of clearing that as well. And with that, I'd like to thank you for your time. And this is the same of our research completed by the 45 and up people. And I'd like to acknowledge our team and our funding sources. And I'm happy to take any questions.
So those online can unmute and ask questions if you have any, because I don't have access, so you cannot put it in the chat box.
Yes, please.
Great talk. So do you see this data at some point kind of being used more like how we use cardiovascular disease risk and mortality?
Great question. We'll hopefully have a prototype in a year, shortly. It's in the works.
Great. I mean, that's what we kind of miss with FRACP. I mean, we get fracture risk, but we don't, I think we neglect the morbidity, you know, obviously there's huge mortality or more, but we don't talk about the mortality. So
yeah,
in general clinical practice, let's say.
No, I think, for us point of view is like patients are always willing to take medications for something if you had a heart attack. Trying to get them to take my bone medications are quite a different kettle of fish. Although I see differences when I see, say, for my patients for endocrine oncology, because it's for the cancer treating, they'll take any amount of bisphosphonates. Doesn't matter. The talk about ONJ is far easier there compared to I'm talking to my osteoporotic patients. So hopefully with extra data, I think I could convince them that, we think about it differently. And I think, what I'm really interested as well is how the clusters are the same in the other diseases as well. And I think that's where we bring into the next part of where I think bone could go as well. Yes?
You showed data that even in the patients who had no other comorbidities, if they had a fracture, they're at higher risk of mortality.
Yes.
What do they die of, those people?
So this is the great question that everyone asks me about. I think that first of all, I think there's initial things. Initially, perhaps what we know is perhaps infection or either just, simply even it takes a lot of energy to heal as well from fractures as well. But I think the direct path to where the trajectory towards after having a fracture and things, that's the next part of our work too. And hopefully that we're trying to see how we can track where they go, how they ended up through their subsequent admissions and all to see how they end up get to where they get to.
I was just thinking about the same thing. I mean, is it alcohol or falls? I mean,
so this group of people, the 45 and up, I didn't include alcohol because I actually did it as a sensitivity analysis. I think the median amount they drink was 1 standard drink. We're talking of an extremely healthy population. And this is why we couldn't answer some of the questions we were hoping to answer simply because they're a bit too healthy. This is your ideal kind of, yeah.
Working with you. Can you just like send me the link again? Yeah.
Go ahead.
Sorry. I thought I had a question.
Ask a question.
Okay, sorry.
Yeah, so the ankle fracture, so that's really surprising to me, right? So
yes.
Because we see a lot of people, especially in Wisconsin, potholes or ice or whatever. So
yeah, it is
hard for me to think that, because I said it yesterday with a ankle fracture. That's why.
I think this is where I think it's a very controversial, because you generally think, maybe especially women in heels, You know, I think you saw, I just saw some in the paper. Actually, when the reviewer came back and asked, have you excluded women with avulsion fractures? Kind of thing was the question as well. And I think, if we look into it, some of the study has actually shown that, ankle fractures, because the bone quality is a bit different, even the BMD for some of these people, and the CT, if you look at it, it actually can predict, look, the story is not complete, it's half and half. Whether they predict subsequent fractures or not. But I think the clear mark for me was in then those who had subsequent fractures. That was the big tick for them not doing so well.
So one last question. So
you can keep asking.
So the electronic medical records. So
yes.
And there are a lot of problems. How they
correct.
They're coded, and so
the data cleaning takes about 9 months.
Yeah. How did you are these data, because people in their hurry, whatever, the diagnoses are not always accurate and stuff. So when you are looking at this big epidemiologic data from electronic health records,
yes.
How do you make sure that they're actually what they say they are? I mean, is there any way of going back and checking these ICD codes or whatever?
So I think you get to know a clinical coder well. They're your best source of help to understand how they're thinking when they're coding as well. Number one. Number two is also there's a lot to learn from following. You just sit there with the data and following the journey. Pick random sample of people to follow the journey to see how they're going. That usually gives a lot of information, what you can do, what you can ascertain. And obviously, it's not going to be pure data. It's not going to be pure data that you clean, but that you understand the limitations of your data and where you can go from it. And I think also this is where 45 and up, for what it's worth, even though it was a very, very healthy patient population, they had the questionnaire, which could verify the diseases. And in general, the same concept works everywhere, right? The diseases that get reimbursed the highest will always get coded in electromedical records. So, so things like procedures usually are always done correctly because it's a hard end. So, and then for us, it's like MIs, myocardial infarction, and diabetes or anything in general, it tends to be coded correctly. Yes. Yes?
In your practice, sort of applying this sort of information, obviously we see a lot of, in the general endocrine world, diabetes and cardiovascular disease. Has this changed what you're doing in terms of screening? Have you changed your practice where you're getting bone densities maybe in these patients to kind of sort of guide therapy or starting treatment earlier in these patients? Or how has it changed your clinical practice?
Well, I would say it hasn't changed as much, but it gives me more to convince my people because I guess I see a very specialized, if you're coming to the bone clinic already, then I hopefully have assessed you for everything, trying to get everything, because I think before they go back to their primary care, they need to have at least dotted the I's so that, and in general, I think there's lots of good studies about treating people even when they're in their early 60s with osteopenia. I think one of the landmark paper was actually, we've been doing it clinically, but now you have a paper that actually says you recommends you doing it. It's the 2018 paper by Ian Reid and his group down in New Zealand in NEGM, where they did bone densities about -2 and just women that are quite healthy in general. They weren't known to have fractures, but turned out about 1/3 of them had a prevalent vertebral fracture. They gave zoledronic acid once every 18 months. So over 6 years, 4 infusions, there was a 40% reduction in hip fractures. So you're talking about people that you don't think necessarily, have turned up to you for anything. I think there's a good argument towards treating because, I think the whole point of managing is so that they can keep doing what they want to do.
Any other questions? Thank you so much.
Thank you. Thank you. Having lunch and meeting someone at lunch.
Yes. Yeah. That's what I'm saying. We can have lunch. I think
Yes, I should be.
Yes, yeah.
Thank you.
Oh, yeah, before I, yeah, please do before I assimilate your.